Hi, everybody. Welcome to our USMLE Step 2 practice session for tackling difficult topics. And my name is Alina Hill. I am a surgery resident, and I am joined by...
Hi everyone, my name's Olivia Negris. I am wrapping up my intern year. I'm an incoming PGY2 dermatology resident and tutor along with Alina. So a little bit about Elite Medical Prep, just before we get started with tonight's content. For those of you who aren't familiar with us, we are a tutoring company that's dedicated to helping students find success on these really critical and really challenging exams that are required throughout our medical training. So we do have services that start all the way back at MCAT, which if you guys are here tonight, you are probably well past that, through the NBME to USMLE and even beyond that. We do offer one-on-one tutoring, which is probably the bulk of our services, but we also do residency advising and help students navigate the application process and mock interviews and all of the fun that comes with applying to residency in the United States. We also have longstanding partnerships with several medical schools, both in the United States and internationally, and we'll host a good bit of tutoring and USMLE content review courses through those partnerships as well, some of which are listed here on the screen.
All right, and then for our challenging Step 2 topics, today we're going to cover biostatistics, bioethics, and SOAP note format questions. And over the last few years, USMLE has actually been getting adding up more bioethics questions, and they have been also making them more challenging. So this is actually something that a lot of my students struggle with. So I think this will be a really useful session.
Yeah, just as Alina said, there's a good bit of these topics on these exams. If you look at like the breakdown of content for USMLE step 1 and 2 between biostats and bioethics, it's close to 15 to 20% of the exam is made up by these topics. So sometimes they can be harder to study or just feel less important to study than some of the basic and clinical sciences, but they really do matter when it comes to succeeding on these tests. I think students find them really challenging because there can be a lot of words on these prompts. We'll go through some of them so you can kind of get exam fatigue as you go through. And there's often just like a less emphasis on them in medical school and in outside resources. So that's why we wanted to do a dedicated session with you all tonight on some of these topics.
All right, and in terms of recommended resources for these topics, biostatistics. So first aid is really great to reference for formulas, very nicely outlined formulas, and they're really the same for step 1 and step 2. They haven't really changed. One of my personal favorites is Randy Neal. He has a lot of YouTube videos on all the different topics in biostatistics. And a little tip, I actually highly encourage my students when they do watch these videos, if there is a sample problem, to actually pause the video, try to solve it on your own, and then continue watching the video. So this makes it more active learning versus, passive learning, which results in a lot less retention. And of course, Divine Intervention podcast is something a lot of my students are big fans of. For bioethics, again, first aid here for, general principles for bioethics. And there's a book called Medical Ethics for the Boards. This outlines just general topics of ethics, as well as it has a lot of practice questions to go through. So it's good for those extra practice questions. And of course, for all of these topics, practice questions are great. If you do struggle with these, I actually recommend not doing just UWorld, but in addition to doing UWorld, maybe also adding these topics, doing these topics in another question bank, such as AMBOSS, which also has a good section for biostatistics and bioethics. So your biggest practice for this will be those practice questions. So don't skip those and do extra if you are really struggling with these.
Okay, and after that, we're going to dive right into reviewing some of these topics. So I have the pleasure of going over biostats with you all. So I'm going to read this prompt and I'm going to try to wait until I'm done reading it out loud, but you can start thinking and even typing, but don't hit submit on your answer selection until I finish reading, just to give everyone a chance to think through the prompt. We are going to ask for your participation as much as possible. So I'm referring to using the chat function here. So please type the letter that indicates the best answer choice in your opinion once I finish reading the prompt. So we have a new biomedical research company called Oocyte, which develops a novel test to detect ovarian cancer at an earlier stage. The Oocyte is positive. The oocyte test is positive in 90% of patients who are diagnosed with ovarian cancer by the current gold standard test. In addition, the oocyte test is positive in about 15% of patients who do not have ovarian cancer. The prevalence of ovarian cancer in the study population is 1,000. For n equals 1,000 is 2%. So what is the specificity of this oocyte test? So give everyone just a couple minutes to answer. Would love to see you guys utilize the chat function to submit what you think. Okay, any takers? I don't know if I'm seeing anything come through on my end. Would love for you guys to use the chat, even if it's a guess. Try to reason through and submit. I can start chatting through this just in the interest of time. As I start kind of explaining the answer, if any light bulbs go off for anyone and you want to throw in your guess, that would be great. Would love to see it. So kind of looking at this, how we break this down. So our test is noted to be positive in 15% of patients who do not have ovarian cancer. There's a number for this value, and that's what we call the false positive rate. So it is positive in patients that do not have ovarian cancer. That is our false positive rate. So it is false positives over false positives plus true negatives. So everyone that's testing negative, whether it's an accurate or inaccurate read, is our bottom number, our denominator. So total, that's the total patients that do not have ovarian cancer. Recall in this case that specificity, when we're talking sensitivity, specificity is the proportion of patients who do not have a condition. In this case, do not have ovarian cancer, who test negative. Okay, so the proportion of patients who do not have a condition, who test negative, that is mathematically equivalent to specificity. So in order to solve this equation, we can see that adding the false positive rate and specificity, it has to equal 100%. So specificity is kind of like our true negative rate plus the false negative rate has to equal 100%. So in this case, we can kind of rearrange these equations to get specificity. So here, let me put this in the chat so everyone can follow with me. I'm going to put where I'm going along with. Perfect. I see Alina was putting this in too. So we know that specificity plus our false positive has to equal 100%. So hopefully everyone followed me through that bit. So then if we rearrange that equation, we can get the following here, that specificity equals 100% minus the false positive rate. And in this case, we have the false positive rate. That is that 15% of patients who tested positive who do not have ovarian cancer. So knowing this bit, 100% minus the 15 would give us our answer. So if we advance to next slide, we can see our answer in this case is B, 85%. A really good mnemonic to remember when we're thinking about sensitivity and specificity is, in this case, we were talking about specificity. It's the SPIN mnemonic. So SP for specificity, and then IN. So a highly specific test, if positive, helps us to rule in the possibility that a patient truly has what we're testing for. If you've never heard the spin or snout mnemonic, drop something in the chat. We're going to talk through the other half of that mnemonic coming up here in just a minute. But if you've never heard of that, I'd love to make sure that you guys understand what that means and how we can use specificity and sensitivity. This 2x2 table is going to come up time and time again when you guys are going through your biostats questions. So if this is something where you see these questions and you get like that pit in your stomach of, oh my gosh, I hate working through these, this is something that you really should try to commit to memory. If you can always think about your top columns being labeled as disease or no disease, you always start with disease, and then in the second column is always no disease. And then when we're on the side labeling it, it's always a positive test on top, followed by negative test in that second row. When we work through these 2x2 tables, there's so many equations that we can derive from these values. So we just talked about false positive rate, which is kind of down in the no disease column. So it was a patient who didn't have a disease who tested positive. So that gave us that B over B plus D equation, which is down kind of in the bottom half of this figure in the no disease column. If you have questions on this, we're going to apply a couple more problems using this, but I would really recommend, if you have any concerns with these equations with sensitivity, specificity, the positive, false positive rates, as well as positive and negative predictive value, you can derive all of these from this 2x2 table. I would recommend writing down these equations so when you work through your practice questions, you can use them. And then something that we like to tell our students is when you are taking your actual test, if there are a few of these questions that you know you struggle with, use your tutorial time in the beginning of the exam to jot some of these down, jog your memory, make yourself feel confident going into the test that you know all of these equations, and have them ready to go. We can go to the next one.
Yeah, and that was a really, really good point, jotting them down. That's exactly what I tell my students too, and it's so helpful. And you already know you're going to get these questions, so you're really saving yourself a lot of time when during the question you kind of could have a little bit of a panic of what the formula is.
Yeah, saving yourself any extra stress of like worrying that you might blank on the equation, or sometimes like in this practice question, you have to rearrange those equations. So if you have the basic ones written out, then when you get kind of a curveball thrown at you that you might have to rearrange the one you've memorized, it's less kind of jarring and stressful. So let's go on to this next question, and let's start with the question itself. So which of the following factors most likely invalidates the author's conclusion? Take a quick glance at answer options A through D, and I'm going to start reading for us. So there's a randomized control trial that is conducted to assess the effectiveness of a new antiarrhythmic drug in patients with recurrent ventricular tachycardia. A total of 100 patients with ventricular tachycardia are randomly assigned to receive either the new drug or a placebo. Results show that the new drug group has fewer episodes of recurrent ventricular tachycardia compared with the placebo group. The difference was found to be statistically significant with a p-value of less than 0.05. The investigators conclude that the new drug can be used to decrease mortality from cardiac arrhythmia. So again, which of the following factors most likely invalidates these authors' conclusions? And there's no math in this one, so I want to see some people putting in their answer choices in the chat. Right, and it looks like you guys are submitting them in the Q&A portion. I see a few A's, I see a B. Last couple seconds. Yes, I see. It looks like chat function is not an option for our participants, but they can do it in the Q&A. So that's fine. That's perfect. Okay. So I think we can wrap it up here. And this is, I think our most popular answer choice was the correct answer, which is A. So extrapolation invalidates our findings because it's relying on assumptions that observed patterns will continue. And this is often not the case in like real world scenarios. And it's really hard to predict future values if factors are changing. So in this case, they're, saying that there's fewer episodes of recurrent VTAC, but we can't necessarily conclude that that's going to decrease mortality in a real world setting, decreasing the episode. So they're kind of extrapolating, they're applying that data beyond like the scope of what they initially intended to set out with this study and, claiming stronger, greater, more broad reaching results than they are able to with the results of this study. So that kind of brings us when we talk about some, errors and validity of studies, we always want to think about type 1 and type 2 error. I feel like the USMLE absolutely loves testing you on type 1 and type 2 error. So I do want to take this time to kind of go through these two concepts. When we talk about our type 1 error, you can see this is labeled up as like the false positive. Type 1 error is also known as the alpha. That's how you'll sometimes see it denoted on exams. So this is an error that occurs if you reject a null hypothesis when it's actually true. So in other words, so rejecting the null means that you are concluding there is a significant effect or relationship when there's actually no relationship. There's no significant finding. So you're rejecting the null hypothesis. And our alpha is usually what we see is that 0.05. That is like the alpha of a study. So when we talk about something being statistically significant, we talk about that in reference to rejecting the null hypothesis. So that's kind of how this alpha ties in to statistical significance. So if we have a type 1 error, again, we're rejecting the null when the null is true. A type 2 error is a false negative. So this happens if you fail to reject the null hypothesis when it's actually false. So you miss finding or detecting a true relationship or true effect when it actually exists. So you accept that there's like no difference. This is denoted by beta, and it's related to the power of a test. Power is not specifically listed on here, but power can be derived by doing 1 minus beta. Sorry, I added a parenthesis in there. Power is 1 minus this beta or 1 minus this type 2 error value. So you'll see this concept come up as well. One of the favorite memory hooks that I have seen and used a lot myself when I was studying for these board exams is the type 1 and type 2 error. If you guys are familiar with the story of the boy who cried wolf, I don't know if anyone or other panelists have heard this, but if you think of type 1 error as being the beginning of the story when the boy is crying wolf, and the null hypothesis is there is no wolf. So he's crying, there's a wolf, and all the villagers run because they believe him. They believe there's a wolf, but the null is actually true. There's no wolf. So everyone believes that there is a difference or a statistically significant finding when there is not. And then type 2 error is what happens later in the story when the boy is crying wolf and wolf and wolf, saying there's a difference, and the villagers don't believe him. And then there actually is a wolf. So kind of the chronicity of that story, I think, can help. The first instance is when everyone believes it, there's no difference. And then in a type 2 error, no one believes it, but there is a difference, the difference being that there's a wolf. I think that's all I have on the type 1 versus 2 errors. Just in the interest of time, we will certainly come back to them in our Q&A session if anyone has questions that have been that have come up in this so far. Now this is identifying study design. So the question STEM is, which of the following most accurately characterizes this study design? A study is conducted to assess physician use of beta-adrenergic blocking agents as treatment for heart failure. A random sample of 5,000 practicing physicians is selected and surveyed using a 10-item validated questionnaire. Researchers stratify the current prescribing patterns by age of physician and by location and practice and type of practice. So which of the following options A through F is going to let us know what is this type of study?
And this is a very common question for study on study designs. You're essentially guaranteed to see these questions on your test, and I think every practice on BME has them as well.
Let me see. Again, there's no math in this one, so I want to see at least a few people shoot out their answers, their guesses to us.
Yes, and you guys can put it in the Q&A.
Yeah, we can see those in there. I see a few have started to come in. Okay, I have a B, I have an F. There's 22 of you and we've got 2 answers. Okay, I have a B, F, a D, a D. Let's give people one more shot to answer. I'd love to see you guys showed up here. You've dedicated your time. Let's see you guys give us some of your best guesses. Think about what this could be. Okay, let's go on and show the answer. I see a whole bunch more came in. Great job, you guys. Definitely the overwhelming majority of folks that answered did choose the correct one, which is D. This is a cross-sectional study. We have explanations for, why these are all incorrect, but I want to focus on actually the next slide. So if we can go down to this is one of my favorite images. That this one, you can find versions of this like Amboss and First Aid. First Aid has a really nice one I like. So thinking about our timeline of when the study is being conducted and how we are studying something over time. So what defines a cross-sectional study? You can see it actually listed at the very top, and it's only in that middle present state section. So in a cross-sectional study type, we are observing a population at one specific point in time. In a cross-sectional study, the investigator is measuring both outcomes and exposures to their subjects at the same time. The most common way you see this come up on USMLE is in a survey. So it's like a one-time survey or possibly like a series of surveys just like over like that they do in one sitting effectively. So they're learning about the exposures, again, exposures and outcomes measured at once. That's not following participants forward. It's not taking their information and looking retrospectively. It's all happening at once. So in this case, if we could just toggle back one just to see the question one more time for folks that might have gotten this one wrong. It's again asking these practicing physicians to stratify their we're like asking about their prescribing patterns. Okay. And then the researchers have that information and can analyze it based on like where the physician is and a few different things, but it's all done in one point at time. The sample is telling us all of that information from a single drop, a single drop in time. I think we have one more biostats question, and it is a long read. So this is where you can get some of the question fatigue when you the USMLE has started to more and more incorporate these abstract style questions. So for folks that have not had as much experience, in like scientific literature and work, this can be challenging and it can be a lot of information to sift through in a short amount of time. So we have, let me just read this for us here. We have a study of, the question is, in children with type 1 diabetes, what factors are associated with increased risk for microalbuminuria and macroalbuminuria? So my approach to looking at these is I actually like to read the question, and then for the sake of time, I actually like to toggle over to the tables. The tables usually where like the juicy information is. I try to make sense of that and then see what are they asking me. So which of the following patient characteristics most increases her risk for developing I'm struggling with this word today, you guys, microalbuminuria over the next 10 years. So we see that this is a 12-year-old girl coming to the office after being diagnosed with diabetes. They give us a few risk factors: that she does smoke, she's not sexually active, 60th percentile for her BMI. They give us her vitals, and then they tell us that, they're asking us what characteristic makes her most at risk. So I like to know what the study is seeking to tell us. That's that first page, the question. What is the question I am being presented with as the test taker? What is USMLE asking me? And then I like to jump to the table. That's usually where the meat of the information needed to answer these questions are. So everyone, in the interest of time, you unfortunately don't have usually, more than a minute to two to answer these questions. So you can't take 5 minutes on exam day to read every word. So kind of getting in the habit of interpreting tables in the context of the study question and the question USMLE is asking you to answer. So we know our patient, they're asking the risk factor for her developing microalbuminuria. So gonna leave this up here for a second. I think I see some people who have already started to post. So I love it. Keep your guesses coming. You guys a couple more minutes. This one had a lot of words and a lot to look through, even just on this table. Okay. I see a lot of folks have put in their choices. I'm seeing A, I'm seeing smoking. Let's toggle over to the answer. And so this one is actually choice D, which is our gender. So in this case, they're wanting us to be able to interpret confidence intervals. So for our confidence intervals, they are going to be significant when they, and this is a hazard ratio. So when you see ratios, if a ratio is 1 to 1 equals 1. So a ratio, if a confidence interval is talking about ratios, if it contains the value of 1, it's containing the null value. It's containing the value that is like there is no difference. So in this case, we're looking at developing microalbuminemia. So we're only curious about this top half of the graph. They're asking us about micro, not macro. So we don't need to really look at the variables in the bottom when we're selecting this answer. So part of this is I like to tell my students, read the right question, give the right answer. It's a silly little phrase, but like they're asking me about micro. So I don't care. This is all distracting information, the second half of the table. Then we're going to look at the ratios. They're saying, what is her greatest risk? So it's going to be a null risk or kind of an indifferent risk if any of these intervals contain the value of 1, which basically all of them do. Most of them. So if we're looking at A1C does not, but this is a really narrow confidence interval, 1.3 to 1.5. Female sex, 1.02 to 2.1 does not. But everything else that we're going through either is 1.0 or contains 1.0 in that 95% confidence interval. And then female sex being the stronger interval because it's 1.4, but it goes all the way up to 2.1. So this is like our big confidence interval, our strongest risk factor in developing microalbuminuria. I am so sorry, I cannot say that word for you all tonight. If you guys have questions on this, type it in the chat and I will answer it as we continue to move on. But hazard ratio, anytime we're talking ratios and confidence intervals, if it's a ratio, again, a ratio of 1 to 1 equals 1, that is our null. Sometimes people think if it's, you need to know if we're talking like true absolute numbers or ratios. And if it's a ratio, 1 is the null, not 0. So sometimes that trips students up. Okay, I think we have moved into the world of ethics. And now you guys get to hear Alina
All
go
right.
through.
So with ethics questions, always they can have these really, really long vignettes. So my approach for this is what I like to do is I actually like to read the question and look over the answers first because that tells me kind of what are my options. So that way I don't spend the whole vignette reading and thinking about something that may not even really be what they're asking about or may not even really be an answer choice. So here they're asking us about the most appropriate next step. And looking at the options, it looks like there is things about assessing patient's competency. There's also things about, the son making the decision. So really just a glance, I don't, read every single thing, but just a glance at this tells me, okay, this might be a question about like mental capacity and decision making in certain situations. So then I would go back to the question, and then I would read the whole thing. So here we have a 75-year-old man who's admitted to the hospital because of a 3-day history of fever. He has type 2 diabetes, hypertension, and COPD. 1 year ago, he had a stroke with residual right lower extremity hemiparesis. They have a list of his medications here. And oftentimes I find that, they may have list like all these medications or all these conditions, but for ethics questions, the big thing to glare from that is, okay, is this somebody who's sick or someone who's not sick, right? We don't, because they're not really going to be kind of asking us about the medical conditions or medications that the patient's taking. Does not drink alcohol, 1 pack of cigarettes for 50 years, widowed, lives alone, 3 adult children, not in acute distress. They give us his weight and his height and BMI. It does look like he has a fever and tachycardia, as well as respirations of 22 and blood pressure 150/90, which is also elevated. We have an O2 set of 96. Scattered and expiratory wheezes are heard. There is dense hemiparesis of right lower extremity. And then appropriate therapy is initiated, but 3 days later, his condition has improved. He's awake, alert, conversing with one of his sons about current events. Again, his vitals are given, and now his vitals are all normal. Discharge plans are discussed with patient, his son, the physician, and a physical therapist. The physical therapist says the patient would be best cared for in a nursing facility. Patient acknowledges that a nursing facility would provide better care for him, but says he would prefer to remain at home with a visiting nurse. And once outside the patient's room, the son says, I have his power of attorney. Don't listen to him. He needs to be in a nursing home. Um, so here with the answer choices, so I'm going to give you guys a couple minutes to take a look at this and go ahead and put your answer in the Q&A and we'll talk through this together. All right, we're starting to get some answers. Okay. Just gonna give you guys a little bit more time and get a few more answers. Okay, everyone seems to be in agreement with our answer. All right, so overall, getting mostly answer A, we've got 1C. So answer A is the correct answer here. So you want to inform the son that the decision is the patient's to make, regardless of the medical team's recommendation. So a few things here. So power of attorney, that only comes into play if the patient cannot make decisions for themselves. So examples of that would be, someone who's sedated, intubated, really cannot make the decisions for themselves, or, they maybe have developed a psychological condition where they have an altered mental status, they don't really know what's going on. So in order to decide whether the patient can make a decision for themselves, we need to assess what we call capacity. So we need to know, is this patient capable of making decisions for themselves? And if they can verbalize to you that they understand what you're telling them as a physician, they understand, the recommendation, and they understand essentially the consequences of accepting or not accepting the recommendation, then that tells you that they do have capacity. And in this question here, we saw that this patient did acknowledge, and he knew essentially that the nursing facility would be better for him. So he acknowledges that, but he still is able. So that tells us he does have capacity. And this really goes into one of the big principles that gets tested with ethics, which is autonomy. And if a patient has capacity, they have autonomy. They can make decisions for themselves. Even though sometimes they may deny medical treatment when it's necessary, that is their decision to make, as long as they understand, they can verbalize that they understand everything that goes into play with their disease and treatment. Other important principles too that are so often tested. So empathy. And I always tell students, if in doubt, choose the most empathetic response that you can find in the answer choices. And sometimes I even push students to just put yourself in the patient's shoes. Which of these choices would you want your physician to say to you? Because oftentimes they ask you, okay, what's the response that you want to give the patient? There's so many questions like this. So really, whatever the most sympathetic, empathetic, understanding response is, those are generally really good answers to go for. You want to really restrain from any sort of judgmental statements. And as you see, a lot of choices that want to trip you up will have these judgmental statements in them. And you want to be respectful in any statement you say to the patient. Um, and again, autonomy, one of the big things. Shared decision making. So this essentially means that the patient can make the decision, and the patient should be included in making the decision. And it is our role as physicians to essentially inform the patient of everything that they need to make the decision and give our recommendation. So that's what shared decision making would entail. And then open-ended questions. This is another good one. So a lot of good answer options are some variation of tell me more. I know in medical school we're taught when we're interviewing a patient, the first thing you always want to ask them is tell me more. So really you want to do a similar thing on these ethics questions. And it's not always going to say tell me more, but it may be like, oh, tell me how you feel about this condition happening to you, right? Or, tell me more about how you feel, um, with what's going on, or how you feel about your diagnosis. So really, and really put essentially giving the patient a chance to tell their side of the story. So those are really, really good answer options to go for. Um, all right, so with that said, now we're going to go through some SOAP note questions. So SOAP note questions will present the patient in the format of a SOAP note. So that's exactly the type of note you would write if you were seeing the patient in clinic. So it's kind of nice because I actually like how it's very organized, but the intimidating part about this is that often these are super, super long. And it can be very intimidating. So just as with the drug ad questions or like the biostats abstract questions that we saw, you really have to sift through a lot of information for these. So again, my approach here is very similar to the ethics questions and very similar to Olivia's approach for the biostats questions. So the first thing I still like to do here is still go to what is the actual question and what are the options. So in this case, they're asking us, which of the following is the best next step in management of this patient? And looking at the options, I can see that there are options for medical treatment, there's options for sending a patient home, there's options for going to the OR for different procedures. So, and seeing essentially basing on this, looks like this might be some form of a question about kidney stones or, possibly testicular torsion, really based on these answers. So then we go back and we can actually go and read. And with this, I always encourage students really try to pay attention to everything that's abnormal here. Any abnormal vitals that you're seeing, anything abnormal on exam, anything abnormal on labs or CT. And this is nice because this is very, very well organized. And if you do use the highlighting feature, which I highly recommend for, especially for questions like this, I would really highlight the things that are abnormal that really stand out to you. So in this case, we have a 55-year-old man who presents to the ED with sudden onset of severe right flank pain radiating to the groin. He has a past medical history of hyperlipidemia and GERD, and he states that he loves eating McDonald's, Burger King, and KFC. He also has a history of prostatitis when he was in his 20s, and his pain is described as excruciating, and he rates it as a 10 out of 10. It started a few hours ago and has been intermittent. He also reports nausea, vomiting, and he feels cold and keeps asking the nurse to bring him blankets. So important things I would note in here, certainly the location of the pain. So severe right flank pain radiating to the groin. You always want to pay attention to the patient's chief complaint, and I always tell students the patient's chief complaint will always be relevant to your answer. It's, almost impossible that it will not be. So And then other things, the fact that this is a few hours ago, so it was an acute onset and it's been intermittent. So paying attention to, is this acute onset? How long has this been going on? That can also help point us towards different pathologies. Um, all right, and then for objective, we have here the vitals. So important things to note. I notice he has a fever. His blood pressure is okay, maybe is slightly a little bit low. He is tachycardic, and they give us his weight and height, which I think for a 6-foot man, that looks pretty okay. Um, and physical exam, we don't have suprapubic tenderness, so that makes me kind of lean away from something such as a UTI. We do have positive CBA tenderness, which really puts me towards the kidney and urinary system. And then testicles descended bilaterally, no obvious deformities or masses. Okay, so maybe not a testicular issue. And I remember there was that answer choice about testicular torsion. So probably without tenderness, without this, probably unlikely that's the correct answer. So see, because you've kind of looked at the answers, as you're reading the vignette, you can actually even start ruling out some answer choices in your head as you go through this. And that makes it simpler once you get back to the answer choices. It makes the question go a lot quicker. And then for labs, I do notice he has a cloudy urinalysis with some positive nitrates, positive leukocyte esterase, white blood cells, red blood cells. So those are kind of things I would really pay attention, especially positive nitrates, positive leukocyte esterase. And then for kidney and ureters, and this is a very good, very diagnostic thing in here. 8 mm calculus located in right renal pelvis, causing obstruction to the renal collecting system. Um, we don't have any evidence of stones or hydronephrosis in the left kidney. So really it is on the right side, there is an obstructive. And as you notice, the imaging findings are generally usually very revealing for pathologies where imaging is necessary. And bladder looks like it's normal. So overall, I'm gonna give you guys a couple minutes. Keep all those things in mind, especially the imaging findings, and go ahead and choose an answer for this and go ahead and put it in the Q&A and we'll talk through this. Getting some different answers here. Okay, getting a lot of A's, some E's. All right, for the sake of time, I will keep moving forward on this. So the answer here is actually D. And something that's going to really help us reason through this is this chart here. And you may recall this from UWorld or a similar chart in UWorld. So whenever someone is presenting with a kidney stone, the first three things we really want to assess for is this patient in sepsis? Does he have acute, do they have acute renal failure, and is there complete obstruction? Really, we did have a fever here, so, and with his blood pressure was slightly low, so this may be somebody who's beginning to have sepsis. And also, in terms of what we saw on the CT here, we said that the stone is here causing obstruction. So we know that we most definitely have obstruction. So here, this would put us towards a yes, which would mean going and getting a urology consult. Now, urology will have to decide what kind of procedure this patient needs. But overall, because this stone is not able to pass through, what we can do is we can put a stent in here, and that would really open up the ureter. And if they said the stone was in the renal pelvis, so it's somewhere around here. I don't know if you guys can see my cursor. But here, it kind of the renal pelvis. So if you put a stent in here, what's going to happen is that ureter's going to open up, and the patient should be able to pass that stone. Um, and because he's now developed a fever, right, his blood pressure is a little low, so somebody again possibly becoming septic, we really want to act fast here, and relieve this obstruction. So overall, with these really big, obnoxiously long questions, don't panic. Start with the question, look at the answer options, look for the big picture. Sometimes you can even kind of go and just look at the imaging or at the labs first, also to see, okay, is there maybe kind of something big significant in imaging or labs, to where maybe you're not really going to need to read every single word of this stem. And if you really can't get it, don't spend too much time on it. I say you should not really be spending more than a minute and a half on any question, because if you really divide up the time, a minute and a half is generally what we have per question. So if you really can't get it in a minute and a half, just choose an answer, mark it, and keep moving forward. All right, I know we have another one here. Do we want to do Q&A for the last 10 minutes here? Or shall we go for another? Well, let's see this. If anyone has any questions, go ahead and drop them in the Q&A. And then if we don't have any questions, we'll go ahead and do another one of these soap note format questions.
And while you guys are potentially thinking of questions, I want to just add to and reiterate something Alina mentioned with these really long soap note questions or those long, abstract style questions. Highlighting pertinent things are so important. And that's really true for any exam question, but really in these long, dense questions, using your highlighting and using process of elimination. At Elite Medical Prep, we really focus on that with our students. So even if you feel like you're making a guess, if you've eliminated answer choice C and B because you took just that bit of time to synthesize the information and try to reason through it, even if you're frustrated that you have to guess, you've given yourself a much higher chance of guessing correctly because you're making an educated guess if you are using process of elimination. So I think that that's something I just wanted to add to. If you see formulas or percentages, you're like, I don't know how they got this number, but I know that this equation would not be the right equation to use for this biostats question. Like this option was not the right one. Cross out what you can and then answer, if it has to be a guess, so be it, and then move on and try not to spend too much time past that.
Yeah, that's really, really great advice, and I definitely second that. And absolutely. And even if you have to decide between two choices, that gives you 50-50 versus deciding between five or seven, right? Or nine. Sometimes they do like to go into these
Yeah.
extremes with an insane amount of choices, but that really narrows it down. And, the more questions you can get, right, the better your score. All right, so we do actually have a question. When facing long clinical vignettes in UWorld, do you recommend reading the last 2 to 3 sentences or the actual question stem first before reading the full passage? Um, so my take on this is I just do the last question. When you're trying to decide if you want to do 2 or 3 sentences or however many, I find that that can kind of really slow you down and add to decision fatigue, which means making another decision as to where you're reading the question. So I always recommend you have one single approach for every question. And the way I do it, and I recommend my students do it, is read the question, look over answer choices, and then go start reading from the top and highlight the important things, and then you're getting back to your answer choices. I don't know, Olivia, maybe you have any other suggestions?
Yeah, no, I'm in the same school of thought where I like to read just that last question stem. I'm kind of plus or minus on reading the answer options. I'll usually glance to just see, like general ballpark, what are they asking me? And then I like to recommend that my students go to the top and read it through. I think giving yourself that framing the context of just the question, then you can go from there. I'll say the caveat is, and to the point of why I don't like to start reading in the middle, is because sometimes it's rare, but there are a handful of questions that will be really straightforward of like, what is the most likely side effect of the new pharmacologic agent this patient just started? And then all you need to do is read that question stem and then find the name of the drug. Like you actually, for some questions, again, not too many, unfortunately, most you have to read everything, but there will be a few that you can save yourself that exam fatigue and reading through a whole dense vignette, and you really just need to find one word. And so you can save yourself some time and energy too.
Yeah, absolutely. Totally agree with that. And you're welcome. All right. So for step 2, do you recommend doing UWorld 2 times or doing UWorld plus Ambas? What a great question. I actually get this question quite a lot. My personal take, and different things work for different people. I always tell students what works for you may not be what works for someone else. So some students will tell me, I started my second pass, but I remember like all the questions, right? And at that point, it kind of defeats the purpose of doing a second, of going through all the same questions. And then maybe in that case, it's a good idea to switch to a different question bank that has different questions the student hasn't seen, like AMBUS. So it depends on your timeline, depends kind of if you remember the question, if you see that you're just recalling the answer choices and maybe that's not really providing you any more value, then you can switch to AMBUS. On the other hand, if you really master UWorld and you know everything in UWorld and you can teach somebody everything in UWorld, there is no way that you're not going to do well in this test. So if you want to kind of really take the time to do UWorld twice, and in the case that you are remembering some stuff, I would encourage you then rather than just putting down an answer choice, explain to yourself why is that the right choice. Is so that you make sure you're not just recalling the correct answer, but you're actually recalling the reasoning as well.
Yeah, I would echo a lot of that. And I think sticking to, some schools provide AMBOSS versus UWorld, I think we have the most data on UWorld, so that's what we're most comfortable talking about. But any of these massive comprehensive question banks, if you work your way through one in completion and do the thousands of questions in there, I think the biggest piece is finding one that you're going to stick with and complete at least a pass on. And then when you're making that second pass through, just like Alina said, if you feel like you are recalling all of them and need to switch gears to a different resource, that's the time. I would not try like working through two simultaneously. I have a few students that have attempted that, and I feel like it becomes very overwhelming and very hard to keep up with. Um, Another question, how can I improve the time it takes me to review a block of UWorld questions without sacrificing comprehension? And this is a question I feel like I get all the time. And something that I like to advise and that I think is a pretty common practice among our tutors here is thinking about how kind of a rough ballpark of how long it should take you to review a block is about twice as long as it took you to take that block. So if we're talking a 40 question block, 1 hour, it should take you an hour to take it and then 2 hours to review it, give or take. I say like between 1.5 and like 3 hours, but because everyone is different and each block will be a little different for you. But I think if you have that kind of 2-to-1 ratio of how long you should be taking, you are going to allow yourself to get into the explanation, review something thoroughly, but not get too deep in the weeds and go down all the different rabbit holes you can go down. You have to, at some point, cut yourself off and trust that if something is high yield enough, there will certainly be a question dedicated to that concept. So allow yourself to, I think a really helpful practice is actually just to time yourself the next time you do review and see how long am I actually spending. If I'm taking 4 hours to review 40 questions, there's no shot you're going to get through as much content as you'd like to. So a little bit of self-awareness, see how long it's taking you, and then see if you can aim for roughly that like 2-to-1 ratio.
Yeah, totally agree with that. And another thing I advise students is with review, read the educational objective first, and then as you review the question, really focus on getting, what was that educational objective, that main takeaway, rather than, as Olivia said, getting into the weeds of every single thing. Because she's right. If it is high yield, you're gonna see it in UWorld multiple times. Like, for example, atrial fibrillation, there's like 20 or 30 UWorld questions on that. So it's a high yield concept. You're going to see it over and over. Um, and then I think we can do one more. Does your question in first pass matter? I use it for shelf two. I always encourage students to use UWorld and any other question bank as the learning tool, not an assessment tool. Your practice exams are your assessment tool. So no, I would say it does not matter as long as you learn from it.
And I think that's one quick thing to add in. When you see the averages, this is for anyone taking it at any point. Someone might be on their third or fourth pass through UWorld. Someone might be doing UWorld in tutor mode with their first aid book open next to them. People use this in all different ways, not necessarily maybe how we would recommend using it, but thinking about that, when you see that, try not to let those discourage you, and you need to do it just like Alina said. It's a learning tool, and you are using it to comprehend, to get exposure to material, and not to like judge yourself against other people's performance, especially on that first pass when you're seeing things for the first time.
Yep, totally.
Okay. I think we got through just about everything in the interest of time. I know we're 8:01 and want to respect everyone's evening or start of the day, depending what part of the world you're joining us from. You certainly know how to reach out to us at Elite Medical Prep. So if there are any follow-ups or you're interested in hearing more about some of the services that we offer or setting up a free consultation, here are the resources on our screen. You can find it all on our website as well. And we would be happy to connect further with you all. I wish everyone the best of luck. I know that this is a beast of an exam, the USMLE Step 2, being 2 days, and it's just so much content. So really proud of you all for being here and showing up and participating with us tonight.
Yeah, thank you everybody. And it was nice of you all to join us. And I hope you got a lot of good tips out of this. And it certainly will be recorded and sent over email as well. So you can always go back and reference what we said.